In terms of treatment strategies for older patients, whether fit or unfit, it is a bit of a complex topic. When we look back at historical data, this has been looked at for many decades. Now, one question is, what's the definition of older patients? It's somewhat arbitrary, although it is based in data that using an age of 60 years or above. Now, we know Hodgkin lymphoma is typically a cancer of young adults, median age in the late 20s and early 30s. But looking at population-based analyses, about 20% of all Hodgkin lymphoma patients are over the age of 60. And we've known for decades that they have a worse outcome compared to their younger matched cohorts. Now, why is that? Well, certainly part of it is they are older patients and generally speaking, more comorbidities, tougher time with treatment, et cetera. But there looks to be a bit more involved in that. And I think that is also multifactorial. Part of it could be biology. Older patients typically have mixed cellularity biology, EBV in the tumor, almost always have advanced stage disease, et cetera. Another part to it is certainly the treatment regimens themselves. Now, we don't think of ABVD as a tough treatment regimen for most patients, certainly not younger patients. But older patients have a harder time, especially if you try to maintain dose intensity. Generally speaking, from an infection standpoint, and in particular, the bleomycin. We know the number one risk factor for bleomycin lung disease is older age, partly because it's a renally clear drug. And bleomycin lung toxicity can not only creep up on the provider and patient, it can be fatal. So I think putting all that together has really represented several barriers in advancing and improving the outcomes for older patients. Now, thankfully, it's been more intently researched over the last 10 years, and this has evolved through a couple different manners. One has been through better incorporation of geriatric assessments. And they're always hard to do, especially in a very busy clinic. But I think in general, it's important for older patients and specifically for Hodgkin lymphoma. Now, do you need to go through an entire battery of testing of geriatric assessments? Can be challenging. I would submit at least an assessment of activities of daily living and comorbidity assessment. We typically do what's called the CIRSG, CIRSG scale, which is really going through past medical, surgical, medication history, et cetera. And it calculates a certain score. Now, there's always a gestalt, is the patient fit or unfit? But I think that gives a little objectivity to help understand, because frankly, for the fit patient, meaning maintains all activities of daily living, low comorbidity score, and I would classify lower as below 10, at least through the lens of Hodgkin lymphoma. The goal should be cure, complete remission, and hopefully avoid relapse, whether it's a 62-year-old, a 72-year-old. And in that case, it would entail multi-agent anthracycline-based chemotherapy. Now, I will often, a priori, not give bleomycin to older patients, especially over age 65 to 70. Not that you can't get away with it, but it's just when you look at whether retrospective or even prospective series, the risk of bleomycin lung toxicity increases each year of age and decade to the point of over 20% incidence over the age of 70. And a significant amount of those, unfortunately, can be fatal. So we'll include it, but if you include it, you have to do it very carefully. Not just tracking, yes, maybe pulmonary function tests, but active questioning, cough, shortness of breath with the patient, et cetera. But of course, another big breakthrough, I believe, in treating older patients with Hodgkin lymphoma has been the incorporation of novel targeted therapeutic agents. We published a multi-center phase 2 study a few years ago integrating Brentuximab Vedotin into frontline treatment of older classical Hodgkin lymphoma patients. That treatment design was predicated that on, yes, efficacy of the targeted agent, but also tolerability. In other words, we started with 2 doses of single agent Brentuximab Vedotin, then went on to AVD chemotherapy, and then finished with single agent Brentuximab Vedotin. And I can tell you that served a couple purposes. One, those first 2 doses really served as an excellent prephase. The response rate, which we assessed, was over 80%, with over a third complete remission. But also was tolerability. We really had much lower rates of peripheral neuropathy seen than when it is given concurrently. But that's one of many studies, and that was mainly, even though we included unfit patients, the excellent outcomes that we saw was in fit patients. The outcomes weren't as good, even with that sequential approach in unfit patients. The good news is there have been some concerted efforts in this older, frail patient population, whether looking at single agent Brentuximab Vedotin or adding single chemotherapy like dacarbazine to Brentuximab Vedotin, as well as a double targeted strategy of Brentuximab Vedotin with checkpoint inhibitor. So several groups have looked at this, and I think I would label that data as encouraging, and we look forward more to that data. And overall, thankfully, there's a concerted effort to study this challenging patient population, but I believe a lot of progress has been made and much more to come.